These days, diabetics are not the only people popping injections. There's another jab in town, and you've probably heard of it. You've probably heard of Ozempic or Mounjaro or Wegovy. It comes in different names, but they're all versions of the so-called miracle drug that everyone loves to talk about or loves to hate, and it's GLP-1s. So they started as a treatment for type 2 diabetes, but now they're helping all kinds of people drop tons of weight. And the question we want to answer is, are they valuable for type 1 diabetics? We just want to kind of evaluate them, setting aside the controversy, the opinions, all the complications in terms of culture that we're experiencing around these GLP-1s, and just figure out, are they any good for us on a medical level as diabetics? But also, what are the downsides, and should we be turning to weight loss drugs at all? So fortunately, Tracy and I have actually tried GLP-1s ourselves, so we have a bit of personal experience to share, and we're going to dive into all of those nitty-gritty questions.
Tiny snack. I thought I could get away with it. Good.
Hello and welcome to Correction Dose, the podcast where we take on a new challenge every month to live our best lives with type 1 diabetes. I'm Kate, a writer and podcaster.
And I'm Tracy, a medical doctor and adventure athlete. We dive into science, stories, practical tips, and expert interviews, covering everything from carbs and exercise to fertility and tech.
Plus, we chat about our own highs and lows, our bruises, and those lovely 2 a.m. alarms, so we can learn to navigate diabetes like pros and hopefully help you do the same. Just a reminder that the content in this podcast is for informational purposes only and should not be considered medical advice.
Kate, shall we dive right in?
Let's do it. Hi, Trace.
Kate, how are you doing?
I'm doing well. I have a new pink microphone, so I'm very excited. But before we get into all the details, can you just tell us in like 1 or 2 sentences, when did you try GLP-1 and how did you find it?
Ages ago, a GLP-1, the OG GLP-1 called Byetta. How did I find it? I was very sick. It was intense. And you've also used a GLP-1 before.
Yes, I was on a clinical trial. They were assessing whether Victoza is good for type 1 diabetics, if it would help with glucose control. And my stomach was not happy. I did lose quite a bit of weight, but at a cost.
Yeah, I was so uncomfortably nauseous for most of the day that my quality of life was really went down the drain. But I did also lose some weight. And I think we're going to get into our Victoza and Byetta experiences properly late in the podcast.
Yeah, we will. I also wanted to ask you, as a doctor, have you noticed more people interested in this drug or asking for this drug?
Oh, 100%. It is, I mean, between like colleagues and the corporate I used to work at, people would always ask, and do you think you could do me a solid? Just give me that prescription. There's definitely an uptake and a lot of curiosity into GLP-1s, as people should be. It's a very fascinating and incredible drug.
Okay, so we'll start with a bit of context, because not everybody is obsessed with these drugs in the way that, well, I have been, and I think a lot of other people have been very interested in them. But they've absolutely exploded in a way I think few other medications have. And most people know someone who's taking them. A lot of celebrities have talked publicly about using them. People like Oprah and Elon Musk, and even Serena Williams, who I think she does invest in a company that makes them. But, you know, as a professional athlete, fascinating that she should be taking a drug that's kind of known for treating obesity. And 1 in 8 Americans are now using GLP-1s, and 1.6 million British people are using them. And they're having a huge effect on, like, financially as well, because Novo Nordisk, which makes Ozempic and Wegovy, is based in Denmark. And at one point, its stock market value exceeded the size of Denmark's annual GDP. So it was bigger than Denmark's economy, essentially. It was the second most valuable company listed in Europe. And food companies like McDonald's have been talking about how they're going to cope because people are eating less. So many people are taking this drug and their appetite is decreasing to the point where it's actually impacting the revenues of food companies. So it's obviously very popular. It obviously works to some degree in some people. And there are other benefits sometimes besides weight loss that we'll talk about, but also some downsides. But I guess I'm interested, like, why is this such a loaded conversation? Because it doesn't feel like a medical conversation anymore. It feels like it's gone beyond that in many ways.
It's gone far beyond just, no one talks about a high blood pressure medication like they talk about a GLP-1. So, there's so many factors that filter into it. But basically, we're discussing these drugs at a time where our body image pressures are so intense, mainly because of social media. We see the skinny culture resurfacing online. We see extremely thin body ideals, and they're kind of finding their way back to mainstream media coming out of, a big movement of body positivity. And we see social platforms like Skinny Talk really dive deep into looking as thin and skinny as possible. So it really makes these conversations about GLP-1s quite complicated and emotional and actually generally quite uncomfortable and inflammatory. It's very polarizing, so people feel quite passionate about it. Now, for some people, these medications, it is genuinely an amazing medication, and people do have meaningful health benefits and generally improved quality of life. But for other people, it can be quite triggering. It can trigger difficult feelings around weight, restrictions, self-worth, and it can inflict a lot of pressure to look a certain way. So there's really stigma from every direction. There's stigma from using the medication, stigma around weight, stigma around assumptions that people are taking drugs for vanity rather than health. And it's difficult because if you had to cancel out all the noise, there is major scientific and clinical potential as well as, of course, risks. But we really need to talk about these medications quite carefully, like compassionately, honestly, and especially if we're going to look at it through the lens of a type 1 diabetic and in the type 1 community, where already as a type 1, there's quite a complex relationship with food, with numbers, with control, with body image. It's already quite loaded and complex. But yeah, it's also to know that GLP-1 medications, they are not currently standard therapy for type 1 diabetes. The research is still evolving. So if you are a type 1 diabetic using a GLP-1, it's generally as an off-label use. We still need insulin. GLP-1s will not ever take away the need for insulin for a type 1 diabetic. But really, this is a conversation you need to be having with your endocrinologist and diabetes care team, because there is a space for GLP-1s in the setting of type 1 diabetes.
Yeah. And it goes without saying, don't buy them from like the lady that works in the back of your hair salon or someone on Instagram.
Oh, and the thing is, you can find them anywhere. There's a lot of people making it and selling it. So it's not necessarily standardized. And then you can also get it for super cheap, like through the black market. There's a major black market for this drug.
Thanks for the tip.
Yeah. Yeah, link in my bio. No, I'm kidding. But funny enough, I had a job interview with this company that was, selling, basically running a GLP weight loss clinic. And they had access to a black market medication, which you could either give them a legitimate prescription or you could put the patient on the black market medication, and then you would get a cut of that medication as well. So every time they bought it, you would, it was just unethical and felt so weird in so many levels. I was like, I can't stand for this, even though I understand the premise that a lot of people do need this medication. And if they can get it at a cheaper price for the exact same thing, and really benefit from it. Like, what is actually unethical is charging huge amounts for this life-changing medication. So, I mean, you can swing it however, but it's a tricky place as a doctor to hang out for sure.
Yeah, I can imagine. But let's get into it. What is a GLP-1 and how do they work?
Okay, so GLP-1, so it stands for glucagon-like peptide 1. So it's an incretin, and I love the word incretin. For some reason, I imagine this like mischievous little like creature running around our bodies. But incretins are gut hormones that are released after we eat food. And it really helps the body regulate blood sugar, appetite, digestion, and energy use. So it really prepares the body to handle the nutrients after you finished eating. It's almost like your incretin links your gut, your pancreas, your brain, and the liver, and creates this nice closed loop in order to handle a meal. So what it goes and does, it'll stimulate, so specifically GLP-1, it'll stimulate insulin. Very unhelpful in a type 1 diabetic because our beta cells are not responding to that signal. But that doesn't mean that it doesn't benefit us in other ways. So it also reduces your glucagon release, which means your blood sugar won't necessarily go as high because glucagon releases more sugar into your blood. It slows stomach emptying, so you'll be able to feel fuller for longer. And therefore, it creates this feeling of like, okay, cool, I'm more full, I'm more satisfied, I'm more satiated, and therefore it reduces your appetite. And there are studies looking into the way it might affect the reward pathways in the brain. I mean, food, a lot of us use food as a nervous system regulator, as a reward pathway. It's a hugely that dopamine relationship, and this drug can actually modulate how we respond to food and how we use it as a reward system.
Yeah, a lot of people talk about how on GLP-1s they experience less food noise. And in case people are unfamiliar with all of these terms, what we're talking about when we talk about like regulating the nervous system and dopamine and everything is like you feel anxious, you feel sad, you feel bored, you feel worried, you eat some food. It's a little like pleasure in your day, and it just helps you feel a little bit better. And a lot of us, I think about food a lot. We see food everywhere when we walk around, especially if you live in a city. There's always food in the tube station. There's just food.
Convenience food is everywhere.
Convenience food. If you get petrol at a petrol station, there's food at the petrol station. There, everything's open all the time. You can order stuff. And I think a lot of us just think about food a lot in between meal times and when we aren't hungry. And if you're at home, you might just open the fridge for no reason and take something out. And I think it's that idea that maybe somehow these medications can reduce that and can just leave your mind free from the food noise, from those signals in your mind telling you to eat, so that you can only eat when you really want to. And that can actually be quite relaxing. Especially if you have a real challenge in terms of weight or difficulties with your relationship with food.
And Kate and I recorded a podcast on listening to your hunger signals. And if you haven't listened to it already, please go listen to it, because we talk a lot about this and how as type 1s we struggle to interpret our hunger signals. And that's where GLP-1 can come and really ease the load, because we do, I think, as a type 1, often most of us experience a lot of food noise, because being a pancreas is like a full-time job. Food and diabetes, they're so linked, and we're constantly assessing our blood sugars and thinking about how we eat, what we eat, how our life revolves around food and bolusing. A GLP-1 has a way of just decreasing that noise. Now, it's important to know that as a type 1 diabetic, we are deficient in insulin. We're not necessarily deficient in GLP-1. We might also be deficient in amylin, because that's also made by our beta cells, which also regulates our hunger signals. But our GLP-1s, we're not classically deficient in them, but there is, what they do look at is that we might have a blunted response to our incretins. We just don't get the same response as a normal person with a normally functioning pancreas. So GLP-1s, by taking them, we're not replacing insulin, but we're just trying to amplify that fullness and that response that we should be getting from our incretins. And they have a possibility of changing how our body handles food, how it handles our hunger, and also has quite a big impact on our glucose variability.
So what are the different medications that are available?
Okay, so I want to talk about, our early GLP-1s, because that's you and I. We were back in our day many years ago when I was put on Byetta. I think I was still in medical school, and my endocrinologist, he's like, you're stable, you're informed. Byetta, which is our earliest GLP-1. He's like, let's give it a go. And because I was really struggling with weight gain, and my mom was always like, you eating all the time. And I'm like, I'm hungry all the time. I don't know. I just can't stop myself. So I went on Byetta. Now Byetta, you had to inject in the morning and the evening. So it was like a short acting GLP-1. Very interestingly, it's actually found in the venom of basically a venomous lizard. I think it's called the Gila monster. So it produces this incretin in their saliva because these lizards don't eat quite often. So they have high concentrations of this incretin in their saliva to actually modulate their appetite so they don't feel distressed by the fact that they're not eating a lot. So I love that scientists do these things, but they found it, isolated it.
Somebody had to milk a lizard for this.
I love science and I love biology. It's just so fascinating. So they found that the protein in the saliva of the lizard was 53% identical to our human GLP-1. So they're like, that'll do. Let's put it in some humans. And I can almost say the fact that it's not 100% close to a GLP-1 is probably why the side effects were so intense. So I started this injection, Byetta, and it was amazing because I felt full for the first time, but it was an absolute roller coaster. I had significant delayed gastric emptying. So my food would only digest hours later, which meant my sugar would only spike hours later. And I would take my insulin and then my sugar would go so low because my food was taking some time to digest. So it was a bit of a roller coaster trying to time my insulin right to how quickly my meal would move through my stomach. The nausea was debilitating to a point where I was like, I actually don't think I'm a joyful person anymore because I'm actually feeling quite sick. But the food noise was gone. I felt like my life didn't revolve around food. I did lose weight, but then there was a point where I was like, it's making me more sick than it is making me happy. So I'm going to not take it anymore. And then I tried Victoza, but you also, you were in a clinical trial with Victoza. And that was the next beneficial medication because now instead of twice a day Victoza, you take once a day. How long did you take Victoza for, Kate?
I suspect the trial was 6 months. I can't remember, but I think it was 6 months. And I had to go every couple of weeks for a blood test, and they were kind of monitoring it to see if it was impacting HbA1c or had any side effects at that stage. And it was the injection looked like an insulin pen. So it was pretty low effort from that point of view. It was just one extra injection. I didn't have any food noise, but what I did notice is essentially at mealtime, I could really only put a tiny amount of food into my body. So I remember ordering sushi once, and normally I'm the kind of girl, I can put away a lot of sushi, way more than anyone needs. And I remember eating 2 little like California rolls. And then I thought I was going to throw up. So I was so full. My tummy just couldn't take it. And like sometimes for lunch, I would just have like a quarter of a piece of bread instead of a sandwich. Like that's how little I could stomach.
Wow.
Or I would feel really ill. I also had a runny tummy. I had tummy aches. And they did get a little bit better over time, but they were still there. I get a lot of joy from food, and there's a real social aspect to food. And the idea of going out for dinner and having like 2 chips
and feeling ill. Yeah,
feeling
for the rest
sick.
of the evening.
I was like, it was depressing. I didn't enjoy food very much anymore. And yeah, I lost a lot of weight, but then I put it all back on. Probably
You stopped the Victoza.
when I stopped, probably within like 6 months, which makes sense because I could eat normally again. So
Yeah.
I think that makes complete sense. I had a lot of headaches, but to be fair, at that time, I wasn't really drinking any water, and I used to survive on coffee and Diet Coke. So yeah,
That'll
it's hard
do
to
it.
say. And I didn't have I didn't have a CGM back then, so I couldn't really tell you
Wow.
in a lot of detail. I'd never heard of pre-bolusing, so I can't tell you in a lot of detail what the sort of diabetes impact was. I know it didn't improve my HbA1c at all.
Do you feel it
Yeah.
improved your quality of life or actually worsened it?
Worsened
Weight
it.
loss aside.
Yeah,
Interesting.
I enjoyed being thinner because that's the world we live in. But that was the only thing I enjoyed about it. The rest, I would say, not being able to eat, to enjoy meals, it was depressing for me, and physically uncomfortable. So, yeah.
Yeah. So I guess with any medication that we might try in our lives, whatever it might be, you're always weighing out like benefits and risks and, what is the goal of the medication. There's so many different things and outcomes you can measure to say, tick, yes, GLP-1s are so effective, but it depends on your goals.
Also, my understanding is that they've improved, right?
Ooh, yes. They have done some serious reflection and self-work because now they're fantastic. They really have come a very long way from Byetta. So the newer generations, we look at Ozempic, which is a GLP-1 receptor agonist, as Byetta and Victoza was. But now from twice a day injections or single day injections, we have our first weekly injection, which already lowers the barrier for entry because a lot of people don't want to do daily injections. We're on daily injections anyway. So like you say, it's not a big deal adding one more. But now a
It's
weekly
cute
injection.
that they care.
I know. And then it had a significantly more potent appetite suppression, and gastric emptying. We saw a little bit less side effects, like the nausea. You might have nausea, you might have constipation, you might have diarrhea, but the severity of them, they're more tolerable as side effects more than like debilitating side effects. So overall, people using GLP-1s, now this is not specific to type 1 diabetes. The research is still catching up with type 1 diabetics. There's not many people who have type 1 are going to be put, off the bat on a GLP-1. But in the general population, we see weight reduction, and better blood sugar control in some people. But now probably the most, I'd say like the cream of the crop currently is Mounjaro. And why this is maybe top notch is it's not just a GLP-1. So it's actually using 2 pathways. It's a dual and incretin agonist. So it is GLP-1, so tick like Ozempic, but it is also a GIP receptor agonist. And that's just another little incretin, stands for glucose dependent insulinotropic polypeptide. Easy to remember,
Holy
rolls off the
mackerel.
tongue. And In addition to the GLP-1, they balance each other quite well, and they just sort of enhance the overall effect of the drug. So improved insulin sensitivity, you feel nice and full, but it also shows like an improvement in metabolic flexibility, how your body handles the food, how your fat stores the excess, calories, how your overall metabolism is slightly modified, which can produce greater weight loss. So if you had to see like a GLP-1 on its own will just turn down the hunger volume, whereas Mounjaro will do that, but it'll also help the body handle energy and insulin more effectively through the GIP pathways. Some studies show that a GIP might reduce the nausea as a side effect of the GLP-1, so you don't get as potent like nausea. And really it's quite an effective drug.
So they're probably a lot better than what we use. People will probably have a better experience if they use them. And they're going to continue to improve and come down in price.
I mean, as a drug manufacturer, you don't want people to stop taking your drug because it's making them too sick. So you're going to work hard at alleviating those side effects, because someone who stops taking the drug is not buying the drug anymore and it's not making you any money.
So let's just get more specific around diabetes for a moment. What exactly are the benefits that diabetics might see? So we know it's not a drug that's currently part of normal standard care for type 1 diabetics, but where are we seeing potential benefits?
All right. So firstly is reduced insulin resistance. So our GLP-1s are used for type 2 diabetes, for better metabolic parameters, for weight loss, which is very beneficial in type 2 diabetes. Weight loss is also beneficial in type 1 diabetes because it does often improve our insulin sensitivity. So this medication might be useful if you have type 1 and you are overweight. Some people do have type 1 diabetes with a significant amount of insulin resistance as well. Sometimes they call it like double diabetes, like type 2 and type 1 wrapped up together. This might be super beneficial. I mean, I'd just like to say, ultimately, lifestyle changes are paramount in managing our blood sugar. And we don't want to negate any of that because that is gold standard. But sometimes these medications are useful as an adjunct to behavior changes as well. That's disclosed. So it can really reduce your insulin resistance, which makes it so much easier to bolus. Your body's more responsive to the insulin you are injecting as a type 1 diabetic, which might mean less insulin as well. Overall, if you are losing weight, a weight reduction can improve your insulin sensitivity, reduce your cardiovascular risk. It might, if you are overweight, it might help you with mobility, getting active. It might improve sleep apnea, and therefore you have better quality of sleep, which filters into your next day and makes you feel a lot better, and really just overall improves your energy levels. Another potential benefit is reduced glucose variability. So some people report that after eating a meal, they have a smoother post-meal glucose pattern. So they're not spiking. So because they have delayed gastric emptying, they don't get that postprandial massive spike that we like to see. So just, which can take off the mental load, but also just make you feel a lot better. And overall, you might just have improved time in range. Caveat to that, because of delayed gastric emptying, it might be a bit more tricky to bolus your insulin because you might actually need to eat and then take your insulin rather than take your pre-bolusing might not be appropriate in your, if you are taking a GLP-1 agonist. Yeah. So overall, hopefully just more stable glucose levels, lower insulin requirements. You might have small HbA1c improvements. The evidence does show that you might have a modest HbA1c reduction, but it's not dramatic. Like, I think people don't jump onto a GLP-1 for massive HbA1c changes. And then, overall, because I think especially your, like Mounjaro, there is, just cardiometabolic benefits. You can have potential improvements in blood pressure. Your kidneys could just be better looked after and in better condition. And overall, your cardiovascular health could look more positive. But yeah, all the major studies would be in obesity and type 2 diabetes. More evidence is needed for me to sit here and be like, this is what we found, in type 1 diabetics and, be able to apply it to people generally.
And then on the flip side, what are the specific downsides and risks for type 1 diabetics using these medications?
Okay, so we'll start with DKA, because this would be on top of our concerns. People might reduce their insulin too aggressively and have an insulin deficiency. Suddenly they're eating less. They might not be drinking as much as they usually do. The risk is of becoming dehydrated, relying too much on your GLP-1 agonist more than like your insulin and your usual diabetes management. So it can put you into DKA, neglecting those key elements of diabetes management. The side effects of a lot of the medications might be vomiting, nausea, diarrhea, constipation. The nausea and vomiting becomes the concerning part, because if you can't eat, you're at risk of getting ketones. You might get dehydrated. You take a bolus, but now you can't keep anything down because you're having such bad side effects to the medication. That poses an immediate risk to your life, having a severe hypoglycemic event. We've also spoken about delayed stomach emptying and the trickiness in bolusing. Really important, because it gives that severe risk of hypoglycemia. And then, this is not only in the type 1 diabetes sector. Muscle loss and underfueling, like people can take something good and then take it too far to fit an aesthetic that is, what people are promoting, like being super skinny. People lose often with a lot of weight, lost very quickly, might have a lot of muscle loss. And also it takes a big knock on your bones. There's a lot of talk of around osteoporosis. Even if it's a GLP-1 or, starvation, if you are not going to give your body enough nutrients, enough energy to do its functioning, you are not going to do well. You are increasing your risk of osteoporosis, losing your period, and just suffering from malnutrition. And that's across the board. And then there could also be a lot of fear around the injection. If I stop, will I gain weight back? And just in general, it can improve your mental health, but it could also deteriorate your mental health and amplify your body image concerns. More pressure to lose weight, obsessive eating patterns. Like instead of, your food noise changes from thinking about like what you're going to eat all the time to being scared of food, or like, why am I hungry now? Oh, I must take more of the medication so that I don't feel that hunger impulse, and like kind of disenfranchising your body and the normal hunger impulses and signals that you might be getting might actually cause fear of like the medication's not working. We still need to eat. We still need to look after ourselves and make sure we're getting our protein, macronutrients, micronutrients, and exercising and strength training and loading our bones and body.
Yeah, I think the element of thin culture is really important around this drug, because on the one hand, we know that losing weight can improve your health. On the other hand, we know that a lot of weight loss culture is not about that. It's about how we look. It's about cultural values around weight. And sometimes I think we don't need to lose weight. You might not look the way that you want to, but that doesn't necessarily mean you need to lose the weight. And some of the people that are taking this drug are not someone you would, at least at first glance, think is in need of it. Serena Williams is an interesting example because after she retired from tennis, obviously there's a huge change in her lifestyle. She was playing sport at a really intense level. I wouldn't be surprised if there was some weight gain. She's changing age, and I don't know her. Maybe there were important health reasons why she decided to take this drug, besides the fact that she's an investor in a company that makes them. But I think it says something, her body looked a little bit different from how it did before. And so she didn't want that to happen. But our bodies change as we age. Our bodies look different. After you've had a baby, your body might look different. Or if you've had an injury, you might put on weight. And sometimes that's okay. And to treat that as a medical problem, it's not always accurate. If you're overweight and you're also experiencing other health symptoms as a result of that, that's something different. On the flip side, I think there's a lot of stigma against using this drug for weight loss. People say it's the lazy way, it's the easy way. There's a lot of nastiness around that. And I think if this is something that's going to help your health, that your doctor recommends, don't listen to that noise. That's also not helpful. Sometimes medications can help us and we should just use them. It's the same way I say, take as much insulin as you need. There's no shame in using medicine to help us when it's safe to do so. And also there's a lot of emphasis, in the UK, they'll only prescribe one to you, as far as I know, if you're also working alongside someone to help you with behavior change. So if you're working on an exercise regime, on a diet plan, that's the only time that they'll prescribe this medication. They prescribe both at the same time. And so that makes a lot of sense. It especially makes sense because if you ever come off the drug, those things are going to help you keep the weight off, which is, going to be a lot harder when the food noise comes back, if it does come back. But also, those things are beneficial in and of themselves. They're really good for you regardless. And so, yeah, I think there's a lot of different things to think about. Think about why you want to lose the weight, whether those things are good, healthy, wholesome values, or they're poisonous things that are coming into your consciousness from outside. And then to be kind of realistic about where the health benefits actually lie. But yeah, I think a good doctor won't recommend it to you unnecessarily. So.
Oh, absolutely. A good doctor will do you right. And it's, unfortunate. There's always a spectrum of people abusing a drug and using it incorrectly, which gives it a bad name. And then we often don't see the really exceptionally positive stories. And I had a patient who had actually she was morbidly obese, and she had so many complications from her obesity, like sleep apnea, reflux. Then she had multiple surgeries for her reflux, and then had complications, and then was in ICU. And then the list was endless. And that was a moment for me where I was like, oh, wow, these drugs are valuable. And I said to her, I was like, have you considered? I am so willing to put you on this, because the complications that you have had because of your weight. And of course she's tried. Of course she's been to Wayless and done this. But we put so much pressure on the individual to be the hero, to be disciplined, to do better, they bring it on themselves. But we have to consider the environment we're in. Like you've said, the amount of convenience food that's around, the access to absolute junk food, how we are overfed and we're not moving. As much blame as we'd like to put on the individual, we also live in an environment that is so toxic. And unfortunately, that environment's not going to change very easily or very quickly. But that's maybe where the benefit of the drug can come in, because it can really have an impact on the individual to more successfully engage with the environment that is often not quite healthy or supportive.
So Trace, who would you say is a good candidate for these drugs and who maybe is not?
It's not necessarily the type 1 that has to be exceptionally overweight that's going to benefit from the medication. Chat to your endocrinologist, speak about your problems that you're having, and then you can see where it might be beneficial. But where I would say there's a lot of caution that is needed is, people with recurrent DKA, if you already have an eating disorder, that is already established, if you are pregnant, it's not great. If you are type 1 diabetic with gastroparesis, where you already really struggle with delayed gastric emptying, some people really have this as a complication of their diabetes, where they already have a lot of reflux, a full stomach for long. If you are already exceptionally lean, it'll be quite dangerous. If you're struggling with your nutrition, just getting your nutrition right, that you're not getting enough calories in. If you're already not eating well, you're not eating a varied diet with lots of macro and micronutrients, it's not going to be for you. It's going to set you further back. And in children and adolescents, you're really going through so much. You do not need to be on a GLP-1 at that stage. If you already have, the list is actually quite long. If you already don't have your period, if you already have decreased bone density, if you have low muscle mass already, it's these things, they're not, necessarily all contraindications, but it would have to be a discussion, really getting on the same page with your practitioner about what the goals are of this treatment. But it's not to be taken lightly. It's not a silver bullet. And intention is really important if you're going to start one of these drugs.
I just wanted to mention a couple of other things that I found quite interesting. There's been a lot of investigative reporting on these drugs and the impact that they've had on people. The New York Times Daily Show did a podcast episode about how they're breaking up marriages.
No way.
Which is very interesting because people are seeing personality changes as well as physical changes. So sometimes it was just that they were both people that ate out a lot, loved certain types of foods. And then one of them suddenly becomes a health freak that exercises. It's difficult, the relationship, the power dynamic. Yeah. Or partners who particularly like a larger body, their partner disappears, And then there's the fact, this sort of element of blunted pleasure signaling. We spoke about food noise. There's a lot of evidence suggesting that these drugs also limit your ability to experience pleasure or feel impulsive with other things. So some people say it's helped them quit smoking. There's some research going into whether drinking, again, if your partner and you used to make a cocktail every night and now you don't drink, that can be tricky. They're investigating, even heroin usage, whether it can help at all. I don't think that's conclusive yet. Libido. So, it's an interesting drug. We don't really understand it yet, but it definitely can have a pretty big impact on you. So I guess we can finish up by saying what we kind of always say about everything, which is, it depends.
We hope this has been informative. We haven't given you a clear answer if you should take them or not, because it depends.
It's not one size fits all, much like all of diabetes. So if you haven't listened to our hunger episode, then do go back to that. I think it's a good companion to this chat.
It's an excellent companion. Before you even consider taking a GLP-1, you should listen to our episode, because I feel like that episode alone can help you and your brain and your pancreas and your hunger signals, way before, adding a GLP-1 can. So please go listen to that episode.
All right, Trace, where can the people find us?
Alrighty, you can find us on Instagram at Correction Dose, and you'll find me on Instagram at Type1Tracy, and the 1 is just a number 1.
And I'm at Kate_verse_T1D. And you can also email Kate, CAIT, at correctiondose.com. And wait, before we go, I have to say, Okay, so before we go, I'm going to try and say this 3 times fast. Glucose-dependent insulinotropic polypeptide. Glucose-dependent insulinotropic
Again.
polypeptide. Glucose-dependent insulinotropic polypeptide.
Fine. Yes. On that note, goodbye.